Back, everyone. Right now, it's a pleasure for me to introduce our next speaker, who will be talking about the role of personalized medicine in lung cancer. We have, from not too far away, from AMITA, we have Dr. Dalal. He's a hematologist and medical oncologist at the AMITA Cancer Institute, a freestanding outpatient center designed specifically for medical and radiation oncology, as well as other cancer-related services, conveniently located in Hinsdale. He serves as the co-chair of the AMITA Thoracic, thank you, Oncology Steering Committee, and is the cancer liaison physician for the Adventist Hinsdale and LaGrange Cancer Centers, a Commission on Cancer accredited comprehensive community hospital cancer program since 1971. Dr. Dalal has a special interest in personalized oncology, using the latest technology in genomic sequencing to better match each patient's unique tumor with the most targeted and effective treatment. He holds a bachelor's degree from the University of Michigan, Ann Arbor, medical degree from Sunny Upstate Medical University, completed his internal medicine residency at the University of Maryland, and his fellowship in hematology and oncology at Loyola University. He has been inducted as a fellow of the American College of Physicians, a distinction earned from colleagues recognizing accomplishments and achievements over and above the practice of medicine. So if we can all please welcome Dr. Dalal.
Yes. Okay. Yeah. All right, thanks everyone and for braving the snow. We'll try to get you out. And I want to make sure I address all the questions you have. We should have time for that. I think as I was preparing this, I was thinking about what I'd want to know in those seats, I guess, either personal or a loved one with cancer, and where are we today? Dr. Malhotra, I'm assuming, has touched on a lot of this, so when I get to the immunotherapy part, if I may kind of go a little faster than usual. If there are questions, though, I'll be happy to address them. So this is where I live/work. This is, I don't know if you guys, I'm sure everyone has seen this. It's right at 294 in Ogden. It's a very nice building. It's nice conveniences of what universities have, where radiation and infusion are in the same place, but free parking and a lot more convenient for the people in our neighborhood. So we like being a community center. So the goals of the presentation, I'd like to highlight the advances of profiling lung cancer to better match targets and treatments, demonstrate the progress in systemic therapy and resulting increase in life expectancy in metastatic non-small cell lung cancer, and briefly discuss a few other topics. So again, probably discussed already, but in lung cancer, we broadly separate into two groups: small cell lung cancer, about 15%, and non-small cell, the others. And that's sort of a basket term. There's several different types of non-small cell lung cancers, but the latter are the majority. Now, women used to be a much lower percentage, but this is actually changing. The percentage of cancers and lung cancers in people, women have been increasing. And so the most recent I saw was around 43% women. It used to be probably like 80% men. And what are the risk factors? Well, I think as you all know, smoking is the biggest risk factor for both. Nearly all small cell lung cancer will be smoking related, and non-smokers can get non-small cell lung cancer as well, but at a lower rate than smokers. You know, smoking marijuana probably has an increased risk, e-cigarettes, prior chemotherapies and radiation, definitely, environmental toxins, secondhand smoke, asbestos, radon, metals, you know, other chemicals, pulmonary fibrosis, HIV, alcohol, you know, may go with the smoking, but diet and genetic factors. Someone asked a good question about, you know, familial risk. There probably are some families that are at a higher risk, but there's no exact test for it, and so we don't routinely do that. This will be my first plug to please quit smoking. And there's my second. So lung cancer screening. So, you know, we talked about, you know, ideally you see someone like Dr. Ferguson before you see me or Dr. Malhotra. How do we find these at an earlier stage when they're potentially curable? So, you know, since we know smokers and recent ex-smokers are at the highest risk, can we screen them earlier and diagnose cancers before they metastasize? can we take what would be an incurable stage 4 cancer, and because usually by the time you have symptoms in lung cancer, it's already advanced. Can we find it months or years earlier at a stage when it could be curable? Can we minimize radiation exposure from CT while doing this? And can we do this relatively inexpensively and also without having a lot of false positives where we're sticking needles in people where we really shouldn't have even looked? And so, I'm glad you asked. So we have low-dose CT lung cancer screening. We have it here at our center. Certainly Rush, U of C, and Northwest Community will have it as well. All places are offering it at a very discounted rate. The idea here is really just to make it, something like mammography, where if you're the right person for it, you should do it, and cost shouldn't be the issue. And so, what does it take to qualify for this? Well, one, you have to be asymptomatic. That means no symptoms. If you're coughing up blood or you're losing weight rapidly, you're not the person for a screening test. You're the person for a diagnostic test. You should get the regular dose CT scan. And when we say low dose, the low dose is the radiation portion, because all CT scans do give you a little bit of radiation exposure. And so one of the concerns, obviously, is in testing people who, most of whom don't have cancer, you don't want to expose them to additional radiation unnecessarily. So ages 55 to 80, a greater than 30 pack year smoking history. So doing that math, it's a pack per day times 30 years, or 2 packs per day times 15 years, or some combination of it. And you'd have to be an active smoker or have quit within the past 15 years. So how this works generally is we get these and we'll review them in a tumor board. And that's what you want. You want everyone on that panel there, as well as a diagnostic radiologist, to review this and figure out what the next best step is. Do we need to repeat a scan in 3 months, 6 months, a year? Do we get a PET scan if we're very concerned? If we're really concerned, we might send you straight to a surgeon like Dr. Ferguson, or to a radiation doctor if surgery wouldn't be an option, or potentially even a biopsy. So again, the effort here is to try to find these earlier, akin to breast cancer and other tests that we have screening for. But you have to be high risk for the scans to be worthwhile. If we did it on the general public, it probably wouldn't show any benefit because you'd be chasing a lot of nothings as much as you're finding things. So let's start with a case, 71-year-old female, former smoker, found to have unintended weight loss and abdominal pain. Again, this wouldn't be a screening person. This would be we need a regular CT scan. What's going on here? And so she has a mass in her left lung there. Whenever you're looking at a CT in a cross section like this, the sides are flipped because it's as if your feet are towards you and the head is back behind the screen. And you look at the CT of the abdomen, and there's multiple liver spots. I mean, don't have to be a radiologist. You can tell there's badness going on there. And so what do we do next? Well, we need to prove that this is cancer. Even when we suspect it, we have to figure out what it is. And in the old days, all we really could say was small cell cancer versus non-small cell lung cancer. And that was basically all the pathologists had to tell us. Things have really changed, as these other guys I'm sure told you. We're really analyzing tumors at a very high level. And so we get a biopsy of the liver. Why do we get the liver biopsy and not the lung biopsy? Well, one, we like to, getting the biopsy of the liver helps us stage it. That confirms that it's a stage 4. I mean, while we suspected it's all one process, in theory you could have 2 different cancers going on. And also, my personal, the medical oncologist opinion, we like to sample what's the most aggressive cancer. What is the cancer cells that are most likely to take the patient's life? Because cancer it starts off as a single cell, but it becomes different clones. And so that's why you see maybe something that a radiation oncologist maybe described, mixed responses, where you're giving a treatment and it seems to be getting smaller in one area, but it's getting worse in another. It's a little bit like evolution going on in your body, where there's certain percentage of this cancer cells will be susceptible to the treatment, but then there's some that'll have a resistance. And so the ones that left the lung and got to the liver, those are the ones that concern me most. So in general, I like biopsying a metastatic spot when possible. The opposites, or in addition to that, biopsying a lung mass, especially in a smoker, brings a higher risk of dropping the lung, collapsing the lung. And so if we can take that risk away, and biopsying a liver is a relatively straightforward procedure, outpatient procedure, that's another reason to prefer doing that. And so we get adenocarcinoma. It's, I guess, a description of the way it looks under the microscope to a pathologist. It looks gland-like. And so we talked about staging, and when we're talking about staging here, there's, your doctor may drive you a couple different ways. The more standard way really is CT scanning. And CT is really, I tell patients that it's kind of a snapshot of what does your body look like. So if a lymph node is big, it's probably concerning. If it's small or normal size, it's less concerning. Well, what if there's cancer cells in a normal size lymph node though? Does the CT scan really not give us as much information? Are we understaging people? One of the things with CT scanning is that to get the IV contrast dye, you need to have good working kidneys. And so sometimes patients, from diabetes, high blood pressure, whatever, may not have good enough kidney function, especially as you get older. And so that's where PET CT offers two things. One, it's looking at activity beyond just what does your body look like. And it's basically analyzing what the energy use is, the activity level of different parts of your body. And so, as I mentioned, there can be a normal size lymph node that has high activity in it, and that would be concerning for cancer. So I always like showing these to patients because you don't have to be, I'm not a radiologist, you don't have to be very good with anatomy to see. The things that are bright in areas that shouldn't be bright, those are concerning for cancer. Now, it doesn't replace a biopsy, right? I can't tell you you have cancer just based on this. I can say I'm suspicious of it. You still need to get the tissue. And beyond just proving that it is cancer, because certain things can trick you. Infections, inflammation, certain rare inflammatory diseases like sarcoidosis, things can trick you. So we do need to get tissue. So in lung cancer, there's a high propensity to reach the brain. And so even if you're asymptomatic, we generally will get an MRI of the brain to ensure that there isn't cancer. About 20% of patients with metastatic stage 4 lung cancer will have brain metastases even without symptoms. MRIs, they use magnets, and so if you have a pacemaker or metal in your body, this was an issue when I was at the VA. A lot of people had shrapnel in them, and they couldn't get MRIs. But they offer very high definition. They're very long. You find out if you're claustrophobic when you need an MRI. I did one in medical school, and I feel bad every time I order one now. And so, they give you very high definition views of the brain. Things that are at the millimeter level. And this is useful because radiation oncologists have advanced a lot in technology, the ability to target specific lesions. We used to just give radiation to the entire brain, but the problem with that is you accelerate dementia and cognitive decline. And as we expect to have patients live longer and longer, getting a good MRI to figure out if the cancer cells are there and targeting the appropriate spots has become even more important. So I mentioned the biopsy. This is me venting. When you're on Medicare, if the biopsy gets done while you're in the hospital, we're not allowed to process it for 14 days. It's a cost issue, but it drives us nuts because there's really effectively a delay of a month because it takes 2 weeks to get the results back, and you can't run it until 2 weeks after you leave the hospital. So that's my 2 cents there. I'd like to find a way to change that. And then, after you get your diagnosis and we've done the staging, it should be reviewed in a multidisciplinary tumor board. Again, like the colleagues you've seen here, you want as many people. We all have our biases, right? I think the drugs work better than they do. Dr. Ferguson thinks surgery is better than it is. Dr. Marwaha thinks radiation is better than it is. And so, you want everyone to sort of beat each other up a little bit and kind of poke holes in everyone's argument to come up with the best course of action. And that's something that certainly all the people you've met here today all agree and do this. So this is what I feel like a lot of doctors, old doctors at least, think we do. We're this nerdy guy looking at blood and chemo, and we make people look like this, all sad. And And that happens, I'm not going to lie. But I think the concept, I feel like there's some doctors that would actually tell patients, oh, don't even bother going to see an oncologist. All they do is make you sick before you die. And I've actually, I mean, in my lifetime, right, I've heard comments like that for things like melanoma and lung cancer. And there is, I get how that started. Almost everybody knows somebody who got chemo and died, or they quit smoking and then they got cancer, is how people phrase it. I always tell people, they didn't quit smoking because they just decided to quit smoking. They started feeling bad because of the cancer and then thought, oh boy, I better quit smoking. And then they found out information. That's generally how that works. But so I'm going to take you on a time capsule here. This is a little bit of why people used to think that. And this wasn't that long ago, right? This is 2002 when it was published. The thought was just give them chemo. Everybody gets chemo. You got lung cancer, you get chemo. And this is a very, you don't have to be a scientist to interpret this. We look at these different curves to see for separation. You'd like to see the curve, the lines separate. That implies that one drug is working better than the others. And you can see here, these just kind of track along each other. They tried 4 different combinations of chemotherapy, and they all kind of worked. None better than the other. You can see at a year, only about 30% of people were alive. So this is kind of what gave us a bad name, is the honest truth. That there weren't people that were really hitting it out of the park. And of course we added toxicities. So when you think about 2005, we're actually going to cut out about 20% of patients here because an 85-year-old probably wouldn't get chemotherapy. We'd say, you know what, too tough on your body, not worth it. And that's not a wrong answer. I mean, we have data that shows that patients with a poor functional status, a poor performance status, didn't benefit from chemotherapy. So it wasn't us being mean, it was just we knew that we would make things worse. And so, you take 20% out, so you've only got 80% of patients that are even eligible for the chemotherapy, and of that, maybe only about 20% even had a response. So that was not that long ago. In 2006 was the first time we actually got to 12 months of an average survival, an overall survival, a median overall survival of 12.3 months. This was big news. I mean, I was in school at the time. I remember thinking, wow, we're really going so far in lung cancer. And you look back on it now, it really wasn't that. It was just because we hit the year mark that I think we got excited. It was a 2-month benefit, and that was adding a drug called bevacizumab or Avastin, an anti-blood vessel drug. It's not a chemotherapy. It's added onto chemotherapy though, and this was a step forward though. We finally hit 12 months, and as we moved forward though, the technology was starting to increase as well, and so it started the sort of the way we thought of it changed. I kind of kindly described chemotherapy as kind of blowing a bomb up in your body, and you're hoping that more of the bad guys die than the good, right? There was nothing smart about it. It was a toxin. It's a poison, and yeah, we picked the right drug to maximize benefit and minimize risk, but you know it. You can't stop hair from going away. You can't stop a lot of the neuropathy that comes with it, and so it was but it's the best we had, and it still works. It's still a main part of what we do. The concept started to become more about precision medicine, and these are meant to be heat-seeking missiles, right? And so an idea of a drug that can separate out the bad guys from the good. And to that point, it started to become less about where did your cancer start. It's more about what makes it tick, what's driving that cancer. So to a certain degree, we're moving to the point where I don't care if it's breast cancer or lung cancer or stomach cancer, just tell me what's driving it, and I'm going to try to find the drug that kills that driver. So in 2009, this was the first time in lung cancer, at least, that we could prove that a drug that was designed to hit a target, something called EGFR. This is a mutation in the epidermal growth factor receptor. You can see, as I told you before, you look for a separation in curves. And so on the left is chemotherapy, and on the right is a drug called gefitinib. And since then, there are actually better drugs than this. But this was the first time a pill, this is a pill drug that's a non-chemotherapy, was actually much better than standard chemotherapy. And this was a real landmark. So this was not something we were testing before. And you can see here, it showed two things. One, in the patients that had the mutation, they did better with the new pill. In the patients who didn't have the mutation, they did worse. So 2009 gave us an opportunity to finally test the tumor beyond just calling it non-small cell lung cancer. We actually would look for a mutation in the patients who had it were better off getting the pill versus chemotherapy. This was a big breakthrough. Now, not a lot of patients have EGFR. It's sort of in different regions of the world, it's a higher risk. So in Asia, and females, never smokers, there's going to be a much higher chance of finding an EGFR mutation. So, 15% is probably a stretch in our community, maybe more like 6 to 8%. But in the world, it probably is, there are places that have a much higher rate. So great. So now we still have, a percentage that can't get chemotherapy, but now we've got an oral drug that is actually better than chemotherapy. In 2010, we discovered something called ALK. It's another glitch in a cell that we can exploit. And this here is called a waterfall plot. It tells you each line, each bar is a patient, and this is showing these dramatic responses. This is 100%. This means a complete remission. There were 5 patients here that had a complete remission to another pill treatment, a drug called crizotinib. I mean, we just never saw it. There was nothing we never told patients that a remission was a possibility in lung cancer. But these patients had dramatic responses. You can see here this entire left lung is full with cancer, and it's totally cleared out. So 2010 added an additional target for us to look at. And they weren't just getting a quick response and then the disease was growing, a month later. These people were going on for, this basically here is 2 years. Again, not even having seen chemotherapy, a pill they're taking daily, doing better than chemotherapy. So you add that to our list now. So now we've got, about 20% of patients here that would start with something different than chemotherapy. In 2010, we also found an additional mutation called ROS1. This is quite rare. I've actually never seen one, but it adds another target for lung cancer. And again, there's another waterfall plot. Sort of the longer the line goes down, the more the response they have is. And you can see only 2 patients didn't respond. Everyone else had a dramatic response. So this adds another 1 person to the non-chemo starting regimen. Dr. Malhotra, I'm sure, talked a lot about this, but immunotherapy has been sort of the biggest move in lung cancer, and these were some of the early reports on this. Talked about setting the body's serial killers loose on cancer and these dramatic responses in patients that probably rightly so. Somebody probably told them 6 to 12 months, and so. The beauty of this is that it's really using something our bodies do anyway. I mean, you can somewhat think of cancer as a failure of the immune system. Our immune system is designed to sort out when cells are misbehaving and sort of command them to die or to right the ship. Those are sort of, we have a whole bunch of T cells in our body that are part of our immune system that are killer cells, and their job is to some degree monitor, beyond just infections. They're there to monitor your cells to make sure that if things are misbehaving, they're not allowed to persist. Now, what makes cancer so tough compared to an infection where it doesn't have the right passport? Your body can tell pretty quickly that a virus or bacteria shouldn't be there. It doesn't have the right makeup of me. But cancer cells are tricky, and the reason we have such a tough time curing cancer is that cancer cells, they carry the right badge. It's kind of like you're at TSA or something. You can't find the guy who's got the missing passport because he's got the right passport. He is you. He's got the right. He tells the immune system, "Hey, don't worry about me. I've one of 2 things. The other says, "Don't worry about me. I'm one of you. I'm a good guy." Or he wears a cloak that protects him from even being seen. And this is what makes cancer so tricky. What immunotherapy does is it revs up the immune system, though. It tries to activate it. I describe it a little bit like, increasing the police force. And so the upside more policemen out there, you got a better chance of finding some bad guys. The downside is there might be a couple rogue policemen on that force too, and so there may be some attacking of your healthy cells as well. And you know, I'm sure Dr. Malhotra talked about that. These are immunotherapy side effects, not chemo side effects. They're side effects of your body attacking your healthy cells. So rash, diarrhea, pneumonitis where it attacks the lungs, hepatitis where it attacks the liver. Most of these can be fairly well controlled with steroids though. So again, compared to, there are a lot of patients I wouldn't give chemotherapy to that I would give immunotherapy to. And so right here I said, you know, patients that previously would have been labeled as untreatable can get these. And cost is probably the biggest side effect. Real briefly, this is a little bit of what I was describing. Your cancer, or your body rather, your immune system presents portions of cancer cells to these T cells. We call them presenting cells. And they basically kind of have a little snippet of the cell and say, what should I do? Do you want to do something with this? Should we be attacking this? And the problem is that these cancer cells do a pretty good job of blocking the attack, basically. It allows for the brakes to be put on the immune system. What these new drugs do, you've probably heard of pembrolizumab or Keytruda, nivolumab, Opdivo, and then atezolizumab, Tecentriq. They work in slightly different ways, but the concept here is that they basically remove the brakes from the immune system. So the immune system is just forced to be on high alert. And the effect is that if in the right cells, in these tumor cells, especially those that express a lot of this antigen called PD-L1, that stands for programmed death ligand 1, the immune system can actually recognize that these cells shouldn't be there. But it sometimes just requires a little boost to say, you know, wake up. And so in 2015, nivolumab was approved in the second line. So after you get chemotherapy first, and then you would get an immunotherapy. And so this was a big deal. So you can see here that these curves are separating. At 12 months or 1 year, 42% of patients were alive in the immunotherapy arm versus just 24% in the chemotherapy arm. And so this was our first introduction into immunotherapy working. And you know, it was groundbreaking for us because we could actually, you know, after first line of chemotherapy, you're a little beat up. And so the fact that we could give something that didn't add additional side effects was a very big deal. And the following year, pembrolizumab came out with their data, and they looked at patients in the first line. Now, what they did was a little bit different. The nivolumab folks, they just took everyone, no matter what, how much PD-L1 was on the tumor cell. You were allowed to give nivolumab. So they weren't selecting out patients that had the highest chance of responding. They just kind of took everyone. And that was really because we didn't know any better at that point. When they started the trial, they didn't know how to predict who was going most likely to respond. We had some suspicions, but they included everybody. So what pembrolizumab did to get its approval in the first line is they picked out the patients that had the highest amount of PD-L1. So again, those are the tumor cells that are a little bit primed. They have a bullseye on them. We just need to kind of encourage the immune system to go find it. And so in the first line, again, these are patients, metastatic cancer patients that have never seen chemotherapy. We're giving them an immunotherapy, and the overall survival, or the progression-free survival, rather, is 10.3 months. That means that's the average. When you look at the survival, you can see that at 12 months, over 60% of patients are alive on the immunotherapy arm, and compare that to less than 50% in the chemotherapy arm. What's even more interesting here is that there's a group of people here that they're not continuing to die off. I mean, usually our lines look like this, and they keep going down, 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 down. There's a percentage of patients here that might actually be in remissions, or the disease is actually controlled to the point where we're starting to think of lung cancer could actually be like a chronic disease. I mean, do we cure diabetes? Nope. Do we cure high blood pressure? Nope. You take your pills, right? You don't get to stop taking your pills after you get your blood pressure controlled. You have to keep taking them. And so this was really eye-opening that, wow, there are some patients here that we might be able to kind of long-term control this. And that was very exciting. And so when you add the folks who have a high PD-L1 expression, so over 50%, and that's a fairly simple test that the pathologist does to basically look at how much of the tumor cells are expressing this target, this bullseye. Then you're now looking at a huge percentage of patients, approaching 50% now, that you wouldn't give chemotherapy to first. And this is all just changed in 15 years. So what is personalized oncology or cancer therapy? I mean, it's kind of what we've been talking about, right? It's how do we line up the right drug with the right patient, right? We want the pink pill to go to the pink patient. We don't want to be given blue that's not going to work on her. And so it's basically, there's two steps to it, right? There's one is what's the right drug for the patient, and also which drugs are not going to work for the patient. Because I certainly don't want to waste my time and let the cancer grow further, giving a drug that's not going to help. And so how do we do that? Well, a big part of this is molecular profiling, and I think someone asked a question earlier about that, and that is genetic testing of sorts. It's not looking at your family history; it's the genetics of the tumor, and that helps us line up. Basically, it helps us describe what color are you, and then how do we get the right pill to you. And so that's what this is all about. Now, there are various different companies, and there's more every week, I feel like. But here's a handful of them. There's one, this is Tempus. There's this Foundation one, Guardant 360, Caris. There's others. Even your 23andMe and those kinds of things. Those are collecting some genetic information on you, but this is specific to cancer. And so we're talking about analyzing the biopsy that was taken and sending it to a company where they usually takes about 3 to 4 weeks to process, but they're coming back with, it started off at about 50, and now I think Dr. Ferguson mentioned over 1,000 different genetic marks on it. Now, I'll be honest with you, 99% of it is garbage. Like it's a big report comes out, and we're talking like 50 pages, and most of it just wasted the toner on my fax machine, right? It's really just a whole bunch of tests that we can find, but we don't know what it means or what to do with it. But we do use it because it does help us look for some of the mutations I was describing earlier, and this is interesting. This was the first company to do it. Others are doing it now too. This is actually a blood test. So we're now able to detect small amounts of circulating DNA. And that's the weird thing about cancer is it's actually shedding parts of it all throughout your body. In some ways, it's amazing it doesn't spread quicker because it has access to your bloodstream. It's able to move around. It's actually harder to set up shop in different places than you might think. But through a blood sample, they can detect, and Foundation One does this as well now, they can detect trace amounts of circulating tumor DNA. And this is useful for the majority of the mutations I was describing. For that PD-L1 test, where you're looking for the immunotherapy, you need to have tissue for that. You need to get a biopsy. So the reason this has actually come in handy, and Foundation One does one as well, is that sometimes when we first get a biopsy, it's done through a bronchoscopy, and they just get a small amount of tissue, and then the pathologist uses up a lot of the tissue, and then you treat somebody for 6 months, a year, and you're like, oh, I want to add another test, and you ask them, and there's nothing left. Getting the blood-based test is helpful when it's positive. If it's negative, you still prefer to analyze it with tissue. So it's one of those where it's useful when it tells you something, but if it doesn't tell you something, it hasn't exactly ruled out that there could be another mutation there. So easy for us to say, but we always like to have tissue. That's, of course, the priority.
Is the blood test detecting
circulating DNA from the tumor. So the reason we can detect that is that we know that there are mutations that shouldn't be in your body, right? The concept here is it's something foreign. It's something that shouldn't be going on. And so they can detect the little glitches in that DNA, like ALK or EGFR or ROS1. It can pick those up because those shouldn't be occurring in a healthy patient. So I won't even get into this. I don't understand a lot of it. Thank goodness a bunch of smarter people figure this out. But this is how they process it. They take the tissue, and you can even use tissue that was saved from years ago, right? This is fresh paraffin embedded tumor samples. So they put it in a little preservative, and you can get those slides out and analyze them later. And so, they basically are looking for a lot of DNA glitches, and it comes out with a report. And so we call this next generation sequencing. I mean, it's not next anymore. It's current. And this is a pretty standard thing to be doing, especially in lung cancer. I think some people are looking in other cancers for it. The cost benefit may not be very high, even in lung cancer, but if you don't look, you don't find it, and that's sort of the medical oncologist line on this one. And it is being approved now. For a long time, it wasn't approved by insurers because it's expensive. It's $3 to $4 grand, and I certainly didn't want to stick patients with that. For a while, the companies were offering it. They said they wouldn't collect, they wouldn't run it through credit or anything like that if you didn't pay. So we were okay with that. Now it's FDA approved, so now they're really trying to collect that. And they weren't doing it out of the goodness of their heart. They weren't just giving free tests. They were collecting the information on you. And not that they were collecting it on you, but they were packaging, let's say, 1,000 lung cancer patients and saying, hey, here are the glitches we found. They could back end sell that to the drug companies to say, hey, here are the glitches we're finding. Why don't you start looking at drugs for this? And I think to me it was a win-win. I think it is where we're going. You may not always need to do these expensive tests first. What a lot of times people will do initially will be looking for the highest yield mutations. So the ones that I showed you the person graph on, where we're kind of looking at first treatments that are non-chemotherapy, those are the ones you need to analyze first. And you don't have to send a $3 grand test for that. You can do sort of isolated testing just for the things that are highest yield. And I think a big use of it is in research. So like where Dr. Ferguson is and Dr. Marwaha, there may be clinical trials ongoing that are looking at drugs that may target certain mutations that we haven't sorted out yet. And so that's always important. So whenever we look for clinical trials, very often they'll want to know that one of these kind of big volume genetic testing has been done to see if there's something that you'd be a candidate for. So, and I just want to sort of stress, we tend to highlight the good points, but the science is way ahead of the clinic, meaning there's still the majority of patients we don't find anything useful by running these tests. And so that's why chemotherapy hasn't left. It still works and still the best we know for the majority of patients in some way, or at some time, I should say. And this, again, is sort of bringing us back to reality a little bit. The bottom lines here are metastatic lung cancer. So again, you don't have to be able to read this, but you can see here that this was 2016 data, and at 2 years, you're looking at about 15% of patients alive in metastatic lung cancer. That's not great to me. I mean, there's a lot of room to do better. But we are seeing some real exceptions, and I think all of us have patients who are exceptions to this older data. I mean, this is sort of collecting data from years before. I think the next time we run a graph like this, you'll see much better numbers. And so there's an additional mutation called BRAF, V600E. And so, when you take it all together, we're talking about 50% of patients now could appropriately be treated with something other than chemotherapy. And I mean, that's really a big change in a disease where we really did nothing for decades before that. The past 20 years have been really remarkable in this, and it doesn't carry the depression that I think I shouldn't. I don't think, and I tell patients that I have a patient who was bedbound when she started, and fortunately had a very good response to the immunotherapy, and just 2 years out now, and certainly able to walk, able to visit with family, and so big improvements are possible. Again, no guarantees, unfortunately. So I just wanted to give a quick list here. Now, the top 4 here have FDA-approved drugs for the mutation we find. And so I think at a minimum, an oncologist should be running, or a pathologist really, should be getting these 4 tests plus that PD-L1, which again is the predictor of immunotherapy. And these bottom 3 are a little bit more experimental in a way. I think they're worth looking for after, perhaps after a first-line or second-line treatment. And these kinds of tests would get picked up on that next generation sequencing I was talking about. But these are considered investigational. You might be able to get them, if you prove that you have this mutation, you might be able to get one of these approved. So it's useful to us to have information to know what to do if the first line chemotherapy works and then stops or doesn't work. But these are very rare. And so, is it cost effective to be testing every single person right at the get-go for it? Some people would say no. But these top 4, I think, are very standard because we have an FDA-approved drug that we can get. And then these 7, I'd say, would probably be the top ones for me, plus PD-L1. So clinical trials. Now, this kind of segues for me a little bit into clinical trials because I told you about the changes that have been made over the past 15 years, and all of this was made because people enrolled on clinical trials. And so whenever we can capture data that tells us that things are really working in real life, as close to real life, clinical trials are probably not real life because they select out patients. And the problem with clinical trials is that you have to be almost super healthy, except for the fact that you have cancer, right? And so, they may disqualify patients who have bad kidney function, patients who are not mobile enough, patients who, may be on a blood thinner, and so a lot of these things make it hard to really say that the stuff on studies is going to apply to everybody, but the studies are kind of the best we have, and that's how we get drugs approved, and that's how we learn from them. Because the hardest part for me now is there are a lot of drugs coming to market, and I don't know the right order to give them sometimes, and I mean, no one does. And so these studies help us sort that out. Many of you may know this already, but there are different phases of clinical trials, and I guess I'll say that trials aren't right for everybody. We certainly encourage them when they're a good trial for you. Phase 1 trials, now these are mostly going to be seen at University of Chicago in our area, maybe a little bit at Northwestern, but these are basically looking for the safety of a drug. So they'll tell you, when you sign a very long consent form, they'll say things like, we have no idea if this is going to do anything for you. And I mean, in layman's term, it'll say, there's a real chance that this is going to have some severe toxicity. Because what they'll do is they'll start at a dose, and then they'll give the next 3 people a higher dose, and then they'll give the next 3 people an even higher dose, and then they figure out what dose makes something really bad happen, and then they come back. And that's important. I mean, we can test in dogs and mice and things like that, but nothing's the same as testing in humans. And so a lot of times this will be a small number of patients. I mean, in our case, it's cancer patients. Don't disregard the healthy part, but they were looking to see, one, is it working? Because a lot of phase 1s will actually not be looking at just lung cancer. They'll be looking at, all right, take a couple breast, take a couple stomach, take a couple lung, and just see if there's a signal of anything working. And this is really just about testing the drug, though. It's not really about saying it's going to work in you. And then phase 2, so after you get past phase 1, let's say that we find a drug and it actually appears to have some benefit in a couple patients with lung cancer. Let's go forward. Now we'll get more patients, all with lung cancer, and test it in a phase 2. And the phase 2 is really checking to see, okay, there was a hint of something in phase 1. Now we've got the drug dose that I think we want to use. Let's see what happens when we give it to a bigger number of patients and see what happens. And so this is looking for effectiveness or efficacy, really, where they're trying to see, does it really work, or was that just sort of, just a little kind of false gold there, fool's gold. Most drugs will fail in phase 2. So kind of looked good when you handpicked a couple people and got some randomness. When you get to phase 2, they don't work. But some do. And the ones that do look promising will go on to a phase 3, and that's confirming the findings in a larger patient population. So when you get to more people, you start finding even some of the rarer side effects. And this has happened in many of our drugs where a drug even gets approved, and then later they have to tell you, oh, actually we're picking up some heart problems or heart arrhythmias or blood clots or something like that. And that's basically, phase 3 is a really high-level trial. Now, if you can find a good phase 3 trial that you're appropriate for, I would certainly encourage it. Phase 1s are basically when you're kind of running out of options. And so that's usually looking, again, because we're testing the drug more than we're trying to help you. I mean, we'd love to help you, but that's not the purpose. So that's sort of a quick overview on trials. Now, if you're interested in trials, and I think everyone should be, there's a website called clinicaltrials.gov, and that's sort of run by the NIH, and it's a worldwide database, though, of active clinical trials. And so you enter in, whatever your situation is and your location, and you can say distance, 50 miles, 100 miles, whatever you're willing to drive, and you can find the trials that are in your area. And so, I put Hinsdale in. We have two, I think, very good trials going on, both immunotherapy trials, one in the second line and one in the first line for patients with metastatic lung cancer, non-small cell lung cancer. And, you could do the same by going to our website, and each university or hospital will have their own, version of this. I wasn't trying to necessarily promote it here, but just to give you an example of if you're a little bit handy on the computer or got a family member who is, you should be able to find out the trials that are in your area. And these change, so it's hard for me to keep up, meaning like, University of Chicago doesn't tell me every time a new trial opens, so I have to look for a patient, or I ask patients to help me look to see if there's something that makes sense in the appropriate setting. All right, is everybody awake? Okay. So real quick, we almost always skip this because it's been really depressing for us for many decades. Small cell lung cancer, and we used to call it oat cell. It's a very fast-growing cancer. I mean, could actually watch it grow, week to week. That's very fast for us. Because it's very fast-growing, it tends to respond very well, actually, to chemotherapy and radiation, because chemotherapy and radiation actually both take advantage of cells that are trying to multiply. So, cancer, all cells really, they go from one cell and then they break into two. And so that process where it's about to separate from one cell to two is a vulnerability time. And that's where chemotherapy and radiation both can, exact its best responses. The problem is, not only is it fast growing, it tends to get resistance very quickly. So you can make the picture look pretty nice after 3-4 months of chemotherapy and radiation, but almost inevitably it's going to come back. And when it comes back, it's now angry and resistant. And so we always want to give that first line, but it tends to come back much higher than any other cancer, really. Very high rates of CNS, central nervous system disease. Again, it really almost has a direct shot to it. If it was 20% with non-small cell, it's much higher in these patients. This is probably the most common site of where patients die from, actually, is spread to the brain. In fact, it has such a high rate that after you get your initial response of chemotherapy and radiation, if you don't have any cancer cells seen, any tumors in your brain, Dr. Marwaha and his colleagues, they'll actually give you radiation to your brain, just assuming that there are some cells in there that we just that aren't big enough yet. And that's really one of the few diseases where we do that. That's called PCI, prophylactic cranial irradiation. And that's because patients tended to die of it in their brain, even if it looked good after the first scan. Down the road, it was almost certainly going to be there. And so, very poor prognosis after initial therapy, and we really haven't moved much. But recently, there's been some change in that, and immunotherapy, probably in combination with chemotherapy, has maybe a potential role here. And there's a new marker that we've found called DLL3, and about 70% of patients with small cell lung cancer have an expression of this marker on their cell. And there's a drug here called rovalpituzumab tesirine. We call it, the short for it is called Rova-T. And up at the top here, I put a picture of the Trojan horse. And this is another concept that hasn't been in lung cancer yet. We have it in other cancers. But you basically find you have an antibody. That's your heat-seeking missile. You need the antibody to find the cancer cell. And then it kind of knocks on the door, and the cancer cell tricks the cancer cell into letting it in. So here's your Trojan horse analogy, right? And so then once the horse is in, once the antibody sort of opens the door, there's a killer, a back-end linker that's got some killer poison in it. So it's a version of chemotherapy, but the chemotherapy is only released once it's inside the cancer cell. So it allows for sort of a high sort of targeting, but really maximizing the side effects, I guess, or the kill part in the cell. So the concept has been there for a long time. The hard part has been, until recently, we didn't have a stable linker. So we could put the antibody and we could have the chemo, but getting it so that the chemo only exploded inside the cancer cell was very difficult. And of course, if it let loose of it before it found the cell, you just got a lot of side effects. And so recently, this antibody drug conjugate, you can think of it as a Trojan horse, has been something that we've been looking at in all cancers. And this is a drug that's been recently developed called Rovati, and they looked at it in patients with relapsed and refractory small cell lung cancer. So these are patients that got their initial chemotherapy and or radiation as appropriate, and the cancer was now growing. And so these patients probably got 1 or 2 chemotherapy lines. It allowed for brain metastases as long as they were stable. And then you had to be in pretty good shape. That's the hard part, is this ECOG PS of 0 or 1 implies that you're basically pretty healthy. You got to be able to walk into clinic. You can probably walk up a flight of stairs. You're selecting out the patients that are a bit healthier. And that's the part that may not be as true to real life as what's really there. But these are what trials do. If they want to get a drug approved, they can't have people that are going to die of a heart attack anyway in the next few weeks. So they're trying to really select out patients that we can find the benefit in. And so this is another waterfall plot. You can see it's not as dramatic as the other ones I showed you, but there's probably a third of the patients didn't have a real response. But down at the bottom here, you can see some real wow ones. And so this is a hint for us. This drug is not approved yet. This drug is not approved yet, but I think it will be soon. And I'm actually trying to get this drug. I think I'll be able to get this drug for a patient even prior to it being approved, because the drug company is allowing for compassionate use. Because really, in the old days, you would just put somebody on hospice at this point. If you had progressed after one round or even 2, and certainly 2, you couldn't sell somebody on the idea that more was going to be better. So if they're in decent enough shape, I think it's something to look forward to. And that's the nice thing, too, is we're able to nowadays get some drugs even outside of the standard, because the standard is catching up to what we're doing. Yeah?
When you say approval soon, what do you mean by soon?
Well, there's a follow-up bigger study. We talked about phase 1, 2, and 3. There's going to be a phase 3 that's going to come out. I don't know when that data is going to be released, but the company AbbVie is allowing it to be used for compassionate use now. So I don't know, FDA is a mystery to me. I don't think they're seeking accelerated approval, so not soon enough for someone who has it right now is my concern as an FDA label, but they're willing to give the drug for no cost. If the doctor you have to go through a lot of loopholes, that's what I'm finding out. But I think my hunch would be a couple years. So in summary, there is hope. I want to stress we don't care. We care it's lung cancer, but we don't really care about that as far as treatment. We're trying to figure out what makes it run and what can we do to stop it. And while not curable in most cases, metastatic non-small cell lung cancer is not the borderline futile disease that it used to be. There's a good percentage of patients that, we all have patients now that are 5-6 years alive with metastatic disease, and it would have been a very rare exception in the past. Now I think all of us have some of these long-term, is it cured? No, I can't use the word cure, but I think maybe we've made it chronic. Maybe the immune system has actually sorted out, all right, we got to suppress these guys. It takes a team. It really does. A multidisciplinary group is really important. We have a very active interventional radiology group that helps us get biopsies that can help hit liver lesions directly. Interventional pulmonology is very active in our partners up north at Alexian Brothers. We refer to them a lot. Radiation oncology and surgery. Someone asked a good question about the role of maybe SBRT or surgery, even in metastatic disease. There are cases where we do that, and especially in the ones who have a targeted treatment. So let's say EGFR, where over a while you might have good control over the liver disease and the right lung disease, but there's just that one spot one part of the other lung that's growing, you might actually do radiation to that or surgery to that. That would be crazy to have thought of, a decade ago. Why would you ever do surgery on a metastatic patient, But now you can actually treat that part and then continue your other treatment. And so there is, we're getting crafty. Clinical trials are always good. It's not a good clinical trial in America, almost certainly will not be guinea pigging you, right? I mean, apart from a phase 1 where it's explicit that we're testing this drug out. These phase 2s and phase 3s won't randomize you to nothing, meaning there's not going to be a chance that you're going to get something less than the standard of care. It's generally going to compare the drug that you would get anyway with the drug you would get anyway plus or minus, plus another drug, a drug we're trying to study. So I think clinical trials are really important. They have a good chance of helping you, but certainly help us figure out what's the best thing in the future. And I'll stress again, we're collaborative. You met some of my colleagues here today. It always bothers me if a patient feels like they have to go behind me to get a second opinion. I would encourage it. In fact, I'll get the paperwork and I'll call them for you. But I just want to make sure you go to the right person, meaning I don't want you to go to the next guy down the block. I want you to see Dr. Ferguson or the lung specialist, whoever the lung specialist is at a university. Because they have clinical trials, they have access to certain things that not everyone's going to have. And so we share. I mean, I share many patients with Rush, Northwestern, UFC, Loyola, and you don't have to pick one doctor. I mean, it's nice even when you're on a trial that they keep me informed, because if Hinsdale or LaGrange is your local hospital, when something goes wrong, I'd like to know what's going on so that I don't have to chase things. And so I would stress that I think patients a lot of times think you have to have one. You don't really. We're a team. We all really want what's best for patients. We actually play pretty nice in the sandbox, and I think patients should be aware of that, because I want you to get treatment where it's convenient, because that's important to a lot of our patients. Again, our cancer center is local for maybe a lot of you guys. I'm not sure. And even if, let's say, you get the recipe from someone at Rush or Northwestern or UofC, if it's not on a trial, you could come get it with us and still see them and me both. And so I think people should be aware of that convenience still matters. If it's going to be where the hospital you're going to go to, if something goes bad at night or 911's going to take you there, probably good to have someone that's aware of what's going on with you. All right, so I wanted to address this. I don't know if it's Pandora's box or not, but given our location, I thought I would get a question on this. And so you guys have all probably heard about this Sterigenics and ethylene oxide. And this is from a lawyer's website, so I'm not endorsing this. I'm just showing what's out there. And they put a list of really a lot of things. I'm not sure how much of this is real. I mean, certainly lawyers are looking to kind of open the net and try to see what cases may fly and what won't. So I wanted to sort of at least separate out what's kind of circulating and what we really know. This is us, right? As far as I could tell. I mean, I live here, and Wellness House is here. This arrow basically encompasses both. And the cancer center is probably just right about here. So it basically shows that, Willowbrook here, which is where the Sterigenics plant is, and I think it's mostly due to air direction that it's kind of carving a northeast pattern. That these are the areas that may be in potential. Certainly the darker area is going to be at highest risk, and then as you get away, it fades out a little bit. But this is because this company, which is it's a company that sterilizes medical equipment, but also food and drugs. So when you get a tablet, from the pharmacy, the reason you don't think there's bacteria in there or something else growing in it is because they use chemicals. And so there's a necessity to what they do. Its location maybe bothers some of us. And I don't know what came first, but certainly this is a very residential area we're all in. The concern is that they've been emitting ethylene oxide, which is a known carcinogen, in the air. Now, from what I understand, and we'll go through this. So the EPA is listed as a known carcinogen since 1985. it's an alkylating agent, and that struck me a little bit because so are my chemos, right? That's like, you don't want that if you don't need it. And it's used to sterilize medical equipment and pharmaceutical drugs and foods. This is one of 16 cities that it operates in. It was, you probably heard this part, it was bought in 2011 by a private equity company that Bruce Rauner has ties to, former governor, I guess. Sterigenics reported in July of this year that they installed state-of-the-art emissions to reduce it by 90%. That's kind of a long time. They have done that. But how much damage has been done is the question, right? And so, about 20,000 people live within a mile of that plant. And the U.S. EPA did do some measurements on the air samples collected in DuPage County, and they thought that they estimated, these are hard estimates to make, which is, I don't want to, it's not hard science, but 6 cases for every 1,000 people is a much higher rate than normal. And so there's a concern. There's a place in Louisiana that's called Cancer Alley because basically there was some emissions of different carcinogens, including ethylene oxide, and so it's concerning when there's a region that has a higher hit rate than you'd expect when you account for things like age, and certainly cancer is a disease of age, but smoking and things like that. You'd think less people are smoking now; it should be decreasing. I couldn't find a lot of real scientific, like I didn't want to just Google websites. So I looked in medical journals, and this is basically a summary of the U.S. EPA's assessment. They thought that there is certainly some carcinogenicity to this, and especially in lymphoid and breast cancers. So we'll have to see where this plays out. I mean, there's going to be class action lawsuits and things. I mean, it'll be hard to prove any individual person's case, right? I mean, if you were a 40-pack-a-year smoker, that's still probably the most likely cause. But it's concerning to me, and I think a lot of the medical professionals in this area, that if this area has a higher than you'd expect amount of cancer, what's going on there? Now, this kind of hit me personally, because a patient even said that she heard rumors about how, you think it's a convenience that the cancer center they built on Ogden in 294 got put up there. I was thinking like we were part of it. I was like, trust me, I would love to be out of a job if cancer was cured. I'll find something else to do. So this is something that's in our community, and I wanted to just address it. I don't have the answers. I think it'll take time to sort through it, but it concerns me. I certainly wouldn't. I'd prefer that they weren't emitting ethylene oxide in such a high population dense area. I think a lot of these other places they have them are more remote.
So what would you suggest to avoid that? Because I hope to get back to swimming soon, and it's right in that neighborhood.
That's the target I go to, yeah.
Cool.
I think, certainly since July, I'm sure their lawyers got to them and said, you need to fix this, because, so I think probably since July, it's come down to a more, I suppose, legal level.
That's what I was diagnosed, so I am like...
Well, that's from damage done. That's from years ago, yeah. Maybe, right? So I don't know the answers to all this, but I certainly have signed a petition of oncologists who've requested that it be shut down until we can sort through the data. But as far as I know, I don't think that's officially happened. I don't know that it helps. This is aerosolized. You could, but I think it's an accumulation of damage over years that worries me, not like a single trip, So we have to be able to control what we can control, I guess. So that's it. Thank you. This is some of my contact information if anyone has questions. And any questions, I'm happy to try to address.
Okay, great. Thank you, Dr. Dalal. So I will open up the floor for some questions, and it looks like we have about 15 minutes.
Yeah.
You talked about PDL and PDL1, and that's programmed death. That's the mutation.
It's actually not a mutation. It's about expression. So PD1 and PDL1 are normal parts of the immune system recognizing cells as being as if they should be there or shouldn't be there. when PD-L1 and PD-1 are allowed to kind of handshake, it tells the immune system to calm down. So what these drugs do is block them from connecting to each other, and that forces the T cell, the fighter cell, to basically be constantly angry, constantly revved up, and go ahead.
So they're not the driver then of that possible cancer or that cancer?
No.
They are merely just a
It's
sidelight?
really getting the immune system to be fired up to recognize that there are cells that aren't there. So this doesn't work in all cancers, and so that's what's interesting, right? So pancreatic cancer doesn't seem to do anything. You'd think if you got the immune system revved up enough, it should say, hey, those guys shouldn't be there, but it doesn't work. It's just not immunogenic enough. And so where this was really started was melanoma. Melanoma and kidney cancer are the two diseases where we've actually known for maybe even a century that there's something about the immune system relation to how the cancer grows. So, going back a very long time, someone recognized that when someone had a tumor, I think it was kidney cancer, it was like at a visible site, they got the flu, and the cancer actually got smaller. And so it was basically because the immune system got fired up. And so we've known this for a long time. We had to use much more toxic medications, something called IL-2, which is occasionally still used now, but basically it gives you the flu. I mean, it is like mimicking you having sepsis or the flu, which feels awful. But the concept there is that, if your immune system can recognize these guys, once it recognizes them, just like when you get the same virus or same cold, it shouldn't be as bad the second time, assuming the exact same strain. That's what the immune system, once it sees it and says, hey, you're not supposed to be here, you have a fighting chance to control it. So, another question?
What does PDL? What do the initials PDL or PDL1 really refer to?
So
I'm going to write it down.
P is programmed. D is death. Yeah. Well, it's about the immune system killing the cells, and then the L is ligand, Ligand. So there's two drugs on the market that are PD-1 blockers, and then there's several others that are PD-L1 blockers. They kind of do the same thing. It's sort of, are you blocking the left hand or the right hand from the handshake? And so the PD-L1 is what is on the tumor. And so that's what we measure the expression of to see if somebody is a candidate for first-line chemotherapy, first-line immunotherapy. Now, the patient, since I probably even first wrote some of those slides, there are patients who have a lower expression. So a lot of patients will have a low expression of PD-L1, either 0 or 5%, 10%, 20%. So those patients you can't give pembrolizumab to first by itself, but you can give it in combination with chemotherapy. And so there's been some very good results for patients, even who have low PD-L1, in getting chemotherapy and immunotherapy. So upside really, nicer responses than we've been seeing maybe ever. Downside is it's very expensive. And another downside is when that doesn't work, you've kind of thrown the kitchen sink at somebody. You've already, and the other downside is it's very expensive, right? So adding immunotherapy to a standard chemotherapy, we're talking hundreds of thousands of dollars in a year, yeah, if not more. But to a certain degree, the cost isn't what we decide on. We just we base it on what we can give that's best for the patient. So it's for the drug companies to drop their price, in my opinion.
My question was along the lines of that. Who are you going to give chemo to, and who will you skip the chemo and go to the immunotherapy? And I suppose it's the PD-L1. Is that what that determines?
Yeah, the high PD-L1. Again, assuming they don't have a targeted mutation, right? So if you have one of those ones I mentioned before, EGFR, ROS1, ALK, one of those little glitches that are kind of rare, but if you find it, then you want to stick to pills, actually. They're much better than chemotherapy. In that case, immunotherapy actually doesn't work as well. When you have one of those mutations, targeting it with the pill treatments is your best option. And there's, many of the pills, you go through the first one, and that stops working, you go to another one.
Well, immunotherapy is the pills, though, right?
No, immunotherapy is an IV.
Oh,
Yeah.
okay.
Yep, so all the immunotherapies we give are IV infusions. Now, they're pretty quick. They're like an hour, don't need nausea medications, there's no risk of reactions, or very
Okay,
minimal.
but some people would still just start out with the chemo, period, right?
Some people, yes, that is still true.
But you'll skip that in some cases and just go to the immunotherapy?
If they have a high expression of that PD-L1,
Uh-huh.
50% or higher,
And when would you just give them the pills?
if they have a mutation that we can target. So that's maybe
Oh.
about 10% of patients, 5 to 10% of patients,
Okay.
maybe less, depending on where you live. Again, higher in Asia and some other, and people who never smoked, and women especially, those are the people who are most likely to have some other glitch that went on. It wasn't a smoking-associated cancer. And the upside is, so traditionally we're always taught that any smoker with cancer did worse than a non-smoker, and men did worse than women. The immunotherapy has flipped that a little bit. Cancer, because smoking causes such damage to your cells, it actually makes the cell look very weird, right? It's got a lot of problems with it. It's not just like one mistake like in EGFR and ALK. It's just a hot mess. And so actually the immune system might actually have a better job finding it. And that's been weird, right? That's been a change for us, because we used to say that, oh yeah, smokers probably aren't going to do as well in the chemo. They're not going to do as well on treatment. And that was, whether we said it to you or not, we were thinking that. But immunotherapy might actually have a higher chance of working in a smoker, a previous smoker, hopefully. Any other questions?
All right.
Great.
Well, thank you,
everyone.
Dr. Dalal.
Thanks for braving the snow.
Okay, real quick, before we wrap up, I do want to introduce Sherry Wick. She's another staff member here at Wellness House.
Really quick, I know everyone is itching to get out of here. Again, I'm Sherry Wick. I am a professional counselor here, and I wanted to invite those that are able to make it to our first Thursday of the month. We have our lung networking group, so an opportunity for you to sit amongst each other, to support each other, to ask questions, to figure out how to continue through this journey. And also, I will be presenting on the stigma around lung cancer March 23rd of 2019, so I would love to see your faces here in the same spot. And I just want to really quickly thank Caitlin for putting this on. I just had to come here and just follow her directions. So thank you all so much.
Thank you. Thank you, Sherry. And again, thank you all for coming today. It was a snowy day. It looks pretty outside, but I want everyone to be safe out there. Before you leave, if you could just hand in your green evaluations. There's a bin Sherry's holding up in the back, and there are some more resources back there for you to take. Have a good one.